I'm just preparing to live stream. Okay, we are going to be live.
No, can you see the slides full screen?
Full screen, yes.
Okay, I'll just move them once. Are they moving?
Yes, I can see them. Yeah, no, now I'm not seeing them moving. Yes, they're moving.
Sure. So now we can go live.
Perfect. Okay. Good evening, everybody. Welcome to the webinar by Concord Biotech on mTOR liver transplantation. We are honored here today to have Dr. Dharmesh Kapoor, consultant liver transplant surgeon from Hyderabad. Dr. Dharmesh, welcome.
Thank you. Thanks.
Thank you so much for being here with us. Over to you, Doctor.
Good evening, everyone, from whichever part of the country you logged in for today's webinar. So the topic for discussion today is the role of mTOR inhibitors in liver transplantation. So as we all know, the liver transplantation has really come of age, and one of the keys to successful outcomes after liver transplantation has been our increasing knowledge and understanding of the immunosuppression strategies. So this is a timetable that of or the timelines of immunosuppressants as they have become available to us over the years. And as you can see that this pipeline has almost dried out in the last decade or so. And the last drugs that were added to this pipeline were belatacept, which really bit the dust in the context of liver transplantation, and Everolimus, which is an mTOR inhibitor, and for which we're probably having this webinar today. So what I really want to drive home is the fact that the number of immunosuppressants that we have at our disposal, they are not increasing in any near time future. And therefore we have to make good our strategies of immunosuppression so that we can have very good outcomes of our patients following liver transplantation. Now, what has always been thought is that when you immunosuppress people, you always are worried about rejection, and therefore you try to go overboard trying to immunosuppress patients. Whereas this particular fear of rejection is actually a little unfounded in the context of liver transplantation, because liver is a privileged organ. And we all know that in spite of the complexity of the surgical procedure and the pre and post-operative management of these patients, once the graft has truly homed in the host, the amount of immunosuppression needed for liver transplant recipients is minuscule compared to other solid organ transplants. And probably this is something that we should take advantage of as liver transplant physicians and surgeons. We should also remember that the long-term outcome after liver transplant is really negatively impacted by immunosuppression. So whether it is the risk of infections or whether it is the risk of recurrence of malignancies, renal impairment, metabolic aberrations, or de novo malignancies, all of these are actually offshoots of the side effects of immunosuppressant agents that we use in these patients. Now, this cartoon is a very detailed one, and I don't think we have time to discuss this, but suffice it to say that there are some key signals of which we make use of when we use immunosuppression for solid organ transplantation. And this is across the board, not just peculiar to the liver transplant recipients. So there is a signal 1, signal 2, and the signal that is very important for today's discussion is the signal 3, which is actually the engagement of the mTOR pathways. And we will come back to this cartoon in a while as this discussion goes on. Now, as a rule, one should probably be tailoring immunosuppression in every single patient. However, things that really catch the physicians and surgeons fancy alike is patients who get transplanted for renal dysfunction and patients who get transplanted for liver cancer. So please remember that almost 20 to 40% of patients who undergo liver transplant in this day and age have some degree of renal dysfunction or they have recovered from one. Whereas about 20 to 25% of all transplant activities across various centers of the world still happens for the liver cancer as being the indication for liver transplantation. Of course, we should also be very much mindful of the metabolic parameters or derangements which exist in a given patient, their phenotype, their predispositions, their comorbidities. And of course, the ideal situation would be that each and every patient who undergoes liver transplantation should be treated differently when it comes to their immunosuppression strategies. So let us first talk about protecting the renal function in the context of liver transplantation, because in the MELD era, this is probably something which is most pertinent to today's discussion. So this can be broadly divided into the early and the late approach. It has been shown categorically and across single center studies as well as registry data that renal dysfunction is extremely common after liver transplantation. To the left, you see the same famous study from the New England Journal, which was published more than a decade ago, which was a data on more than 36,000 liver transplant recipients. And there it was seen that if you were to define renal failure with an eGFR of less than 29 mils per minute, there is almost 18% chance at 5 years and 25% chance at 10 years that your patients would develop renal dysfunction. You might argue that registry data are not truly reflective of what individual center practices, but on the right, you see a single center experience, again from a large series from Baylor, where it can be seen that almost 5% of patients will have such advanced renal dysfunction after liver transplantation that they might even need renal transplantation as a follow-up management plan for their renal dysfunction. And about 10% will go on to develop ESRD, and almost 15 to 16% of patients, by the time it is 10 years or 1 decade into transplant, they will have some degree of chronic kidney disease. So this problem is definitely a very important problem that we are faced with from time to time. Now, the reason for such dismal renal outcomes in the past, I think, was the renal influence on our practice. So the renal physicians and renal transplant physicians and surgeons were always very much used to using much higher levels or trough levels of the immunosuppressants than we actually need for liver transplant recipients. And like I said right at the outset, that the fear of rejection, especially in the yester years, when a bulk of the transplants used to happen for hepatitis C indication, was a very potent fear. And we all knew that the hepatitis C would get aggravated and it would produce more fibrosis in the context of anti-rejection treatment. And therefore, we were always erring on the side of over immunosuppressing our patients. And I think these data that you saw a little while ago from the UNOS and from the single center, these data might have looked different if we were not confronted by the hepatitis C virus as the commonest indication of transplant in that era. So hepatitis C virus, I think, was singularly responsible for most of us having immunosuppressed our patients excessively. So has the situation changed after the DAs have come, or the directly acting antivirals have come in the context of hepatitis C? Probably the answer is a mixed one. So we now have the introduction of the MELD score, in which we have the creatinine, serum creatinine value playing a very important role. And that actually is a big contributor to the MELD score, and patients only with high MELD score come to the transplant table. We started prioritizing patients who are extremely sick, the typical high melders, more than 35, patients with acute on chronic liver failure, patients who either recovered from their acute kidney injury or still have some acute kidney dysfunction at the time they get transplanted, patients with metabolic syndrome, which has components as diabetes, hypertension, and of course, we still are focused on the calcineurin inhibitors as being the most important immunosuppressant agents in our basket. And all of these contribute to renal dysfunction after liver transplantation. And we all know that it is the renal function or the need of renal replacement therapy which also increases the cardiovascular risk for these patients. So it is not just the kidney alone, but once you have got some degree of renal dysfunction set in a patient post liver transplant, you also have to be very aware of the cardiovascular risk that it carries along with it. So this is again a study from the same group, wherein it was shown that CNI toxicity was the most important cause of renal injury post liver transplant, and the other causes also are highlighted in this bar diagram. But all said and done, it was the CNIs which were the biggest culprit. And then this trial, which was the TRI trial, which showed that even for all comers who undergo liver transplantation, you will have about 53% of patients who would have an eGFR of less than 60. That means they would be CKD3 at 5 years, and you would have about 5% of patients who would have an eGFR of less than 30 at the end of 5 years. So definitely this problem of renal dysfunction following liver transplant is a problem that we all have to contend with, and we should have some safe and sound strategies in place to counter this. So what are the let us see what are the things which we can alter in this scenario. And the most important thing that you can alter is your immunosuppression strategies, because all other things might not change substantially. So we would still end up transplanting very sick patients. We would still end up transplanting patients who have got some degree of renal dysfunction, and we cannot do without transplanting people with comorbidities. So I think the most important thing that we can probably tweak is the immunosuppression strategy by way of the use of calcineurin inhibitors. Now, these strategies could be defined as those which are early. That means you start tweaking the CNIs as early as less than 1 month. Unfortunately, in the liver transplant literature, the studies which highlight this particular aspect of immunosuppression are very few and far between. Most studies are delayed or late. So delayed strategy is when you start tweaking the CNIs after the first 4 to 6 weeks of transplantation, and late is when you do that after a year of the CNIs having been on board. So this was the first study, which was of course not concerning the mTOR inhibitors, but which stated or which highlighted the fact that if you were able to delay the initiation of CNIs, again that led to some improvement in the renal function when these patients were followed up for a fair length of time. So this study came from the Birmingham group by Dr. James Newberger, in which there were 3 groups. The first group was the standard TAC group, wherein the trough levels of more than 10 nanograms per mil were the target, and these patients received the corticosteroid therapy. The second group was the one in which the patients received anti-metabolites as mycophenolate mofetil in the dose of 2 grams per day for adult population. TAC was reduced to less than equal to 8 nanograms per mil and corticosteroids. And in the third group, there was an induction with daclizumab, which is an IL-2 receptor antagonist. And then there was a delayed TAC introduction at day 5. So daclizumab was given on day 1 and day 7, and corticosteroids were of course continued as in the arms A and B. So what did these authors find? These authors found that the change of creatinine at month 12 in the TAC standard, in the TAC reduced and TAC delayed varied significantly. And between the standard TAC arm and the TAC delayed arm, there was a statistically significant difference in the change of serum creatinine values. So the fear was that if you are using less CNIs, are you predisposed to biopsy-proven acute cellular rejection or suspected acute cellular rejection? And it was seen that the rate of BPAR in the TAC standard was actually higher than the TAC delayed. So 2 things were highlighted: A, that you could start the CNIs late, and 2, that your fear of a BPAR or an ACR or suspected ACR was unfounded in this cohort of patients. The next study was the introduction of the mTOR inhibitors, and this study of course was published more than 13 years ago. Now again, like I mentioned, that this was a late trial. That means after 1 year of transplantation, patients were randomized either to Everolimus CNI minimization or elimination group, wherein the Everolimus was initiated at a low trough level. The moment this was done, the mycophenolate and azathioprine were discontinued. The tacrolimus and the or cyclosporin dose was reduced by 50%. And if the patients were on corticosteroids, they were continued in the same dose. And after the CNIs were discontinued, the patient continued to receive everolimus, albeit at a higher trough level and plus minus corticosteroids. The other arm was the continuation of the CNI regimen in the same way as it was existing at the time these patients were randomized, which was a trough tacrolimus level of 3 to 8 nanograms per mil, with or without the anti-metabolites, with or without the corticosteroids. But mind you, this happened almost more than a year into transplantation. And then these patients were followed up. And what were the results? The results were that over 1 year, there was not much difference between the everolimus arm and the control arm. So the increment in the mean creatinine clearance was only about 1.3. So what does this study tell us? That if you have to have a strategy of CNI tweaking or CNI minimization or CNI elimination, it probably needs to be on board sooner than the first year post-transplantation. And indeed, we know that the maximum amount of a reduction in the eGFR happens after solid organ transplants in the month 3 to 6. And this is particularly true for liver transplantation. And probably whatever strategies we have, they should be instituted much sooner than what was done in this study. So there are three more randomized controlled trials which have looked at the CNI minimization or the withdrawal. And these are the H2304, the PROTECT trial and SIMSA trial. And I'll be talking about a few of these in some detail. So let's first see what these, how these trials compare. The most important thing in these trials is that the time of CNI withdrawal was only by the time it was more than 3 months into transplant. So like I said, that 3 to 6 months is the crucial period. So in some ways they were able to achieve that target, but maybe this is also a kind of an insight for us that maybe sooner is better. They all looked at the target levels of everolimus once the CNI was significantly minimized or off the table to 6 to 10 nanograms per mil. Again, something that we need to talk about, whether this higher dose is needed for patients in our part of the world. And then some of these studies used induction therapy and others didn't. So let's first talk about the first trial that was published in this space, which was the PROTECT trial. So again, this was a multi-centric European study, and there were two arms, one with everolimus, the other one with the CNIs. And as you can see, that there was a fair length of a run-in period, screening, a period of CNI reduction, and then the CNIs were continued for a fair length of time before they could be discontinued only in a proportion of patients. And in all these studies, what one has tried to study is the change in eGFR at month 12 and some longer follow-up available in some studies, and what is called as a composite efficacy failure. Now, how do you define this composite efficacy failure? Because those of us who are interested in this topic would read this not just in the context of liver transplant, but other solid organ transplants also. So this is defined as biopsy-proven acute cellular rejection, graft loss, death of the patient, or the patient having been lost to follow-up. So these are what are called as the components of the composite efficacy failure. So let's see the results of the PROTECT trial. So you can see that the white bars are the CNIs and the filled dark bars are everolimus. And here you can see that both of them are comparing almost in an equivalent manner with respect to the death, the graft loss, any BPAR or treated BPARs, even though you can see that in everolimus there is a slightly numerically higher percentage of patients who have any BPAR or a treated BPAR, but anything with respect to graft loss, death or graft loss or BPAR, or death or graft loss or treated BPAR, that is all equivalent when it comes to the two arms. And when you talk of the composite efficacy failure, again, the two groups are very much comparable. So this suggests that CNI minimization and in a proportion of patients elimination can be a useful strategy in the liver transplant recipients. So what was the benefit with respect to renal function? So this benefit was only a modest one, about 8 mils per minute of increased eGFR after about 11 months of treatment. But of course, this was a kind of a proof of concept to say that you could do this, you could tweak the CNIs and you could get the CNIs off in a proportion of patients and have some improvement in GFR when these patients were followed up for up to a year. The next important study was the H2304 study and its extension arm, which was the E1. This particular study had 3 arms: TAC elimination, everolimus plus reduced TAC, and the TAC control arm. And as you can see in the bars, you see the trough levels, which were the targets for these patients at the time everolimus was introduced. Now again, you can see that in the first 30 days, these patients have received the standard TAC doses along with the antimetabolites and corticosteroids. Corticosteroids could be continued for some length even after introduction of everolimus, but the attempt was made to discontinue corticosteroids definitely by the end of 1 year. So because there was an extraordinarily high incidence of rejection in the TAC elimination arm, this particular arm was discontinued after the first year of the trial. So this is a very important thing to remember, that in all comers, this might not be a strategy that would work, that you take off TAC completely from the patient's immunosuppression regimen and replace it by an mTOR inhibitor. But does it hold on a patient-to-patient basis? That is something that we would like to discuss during the course of this talk. So now essentially for the extension arm, we had 2 cohort of patients. One was everolimus plus reduced TAC and the other one was TAC control. And as you can see that these patients initially had higher trough levels of TAC, and then by the time it was month 4, these TAC levels were, trough levels were significantly reduced. So what was the net outcome? So these patients were followed up for more than 5 years So as you can see, of course, the maximum increment in the eGFR was in the TAC elimination arm, but like I said, after the first year, this arm was discontinued. And then subsequently, these authors found that in the TAC everolimus plus reduced TAC arm, there was a significant change when it came to the improvement in the eGFR. So you can see that the unfilled squares, they are the everolimus plus reduced TAC, and the triangles are the TAC control. So at the end of 24 months, there is almost a difference of 10 mils per minute of eGFR in this group of patients. And on further follow-up also, this particular improvement in the eGFR was sustained. So the important thing to remember is that an everolimus plus reduced TAC definitely is a strategy to protect the kidneys, and you will have an increment of about 10 to 12 mils per minute of eGFR when these patients are followed up long term. What about the composite efficacy failure? Again, you can see that with respect to any biopsy proven acute cellular rejection, the everolimus reduced TAC was actually lower than the TAC control. For treated and biopsy proven acute cellular rejection, again, numerically, the TAC control arm was higher, but this did not achieve any statistical significance. With respect to graft loss and death, both these two arms were comparable. So you might be led into believing that you are reducing the TAC, and therefore, by introduction of everolimus, these patients might have a higher incidence of BPAR, but this was not found to be true. So this message from this study is that even on long-term follow-up of these patients, the increment in eGFR remains sustained, and that probably the introduction of a everolimus with reduced dose tacrolimus probably has a positive benefit to the graft outcome and with respect to acute cellular rejection. So let us see how we can use these particular strategies in our day-to-day practice of liver transplantation. So let's do that by going through a real-life case scenario of a patient who undergoes transplant. This was a patient who came to our center, 70 years of age. He was diagnosed with chronic liver disease 1.5 years prior to coming to our center. And this was with features of decompensation in the form of ascites. Initially, he was diuretic responsive, and then over a period of time, there was worsening of symptoms in spite of diuretics, and he needed regular large volume paracentesis. And this patient did not have any other features like GI bleed, and he had significant abdominal distension needing repeated paracentesis, and his average urine output on a daily basis was less than 500 mils per day. He was known to have diabetes for last 10 years. He was on insulin therapy at the time he reported to us. There was no other medical history or surgical history of note, and there was no significant personal history too. And his etiologic workup was negative, except for the diabetes this gentleman had, and we thought that this was a decompensated NAS cirrhosis with diuretic refractory ascites as being the main indication for liver transplantation. His baseline creatinine value was 1.4 milligram deciliter. So like I said right at the outset, increasingly we are seeing patients who have got some degree of renal dysfunction at the time they come for transplant. During the waiting time for the transplant, his creatinine values, they fluctuated between 1.6 to 2.1, and the urinary 24 hours protein was 120 milligrams, and the UPC ratio, or urine protein to creatinine ratio, was 0.15. And his eGFR by the Cockcroft-Gault formula was 21.7 mils per minute per 1.73 meter square, which means he was CKD3. And with respect to his MDRD6 equation, his eGFR was again falling in the category of CKD3. So this was his imaging. So these kidneys look fine, but if you were to look at their vascular phases, and this is something that we do typically for the liver only, but not for the kidneys, you can see what is going on at the ostia of the renal artery. So this gentleman, who's a long-standing diabetic, 70 years of age, he has got significant atherosclerotic changes in the renal arteries, and probably these are the reasons why these patients have fluctuating serum creatinine values whenever they have an intercurrent insult. So I think the important highlights from the history and the wait list period timelines for this patient are the fluctuating creatinine values. So you must be able to get the creatinine values back when you treat these patients whenever there is a blip in the renal dysfunction. And second is that you also must have a good handle on what this patient's protein excretion rate is, because that will be instrumental in you deciding the immunosuppression strategy. So he underwent a deceased donor liver transplant after being on the wait list for 4 months. his post-transplant period, his transplant surgery was uneventful. He needed 1 unit of intraoperative packed red blood cell volume. And here we have a case scenario of a gentleman who's got some degree of chronic kidney disease, long-standing diabetes, and 70 years of age. So the question that comes to mind is, would one want this patient to be on a regular immunosuppression strategy post-surgery, or would you want to tailor it to the needs of this patient? So what are the typical phenotypes? That he is elderly, that he is typically not very sick or high acuity, but he has got a chronic problem of diabetes and chronic kidney disease, and he does not have significant proteinuria. So these are the three most important aspects of his history, which should actually help us decide his immunosuppression strategy. So this is what happens to this patient. You can see that at the time that he's shifted to the liver intensive care after transplant, this is what his numbers look like. On the following day, this is what his numbers look like. Our standard immunosuppression is with corticosteroids in the initial period. We taper the corticosteroids every 5 days by about 5 milligrams, and until such time the patient comes on to a maintenance days. And in most instances, our patients would be off corticosteroids by week 12, except those who have either been transplanted for acute liver failure or who have got autoimmune chronic liver disease or autoimmune hepatitis as the cause of liver transplantation. And then we also are very quick to add the anti-metabolites in these patients. So you can see that in this particular patient, our preferred immunosuppression on the first day of the transplant was not tacrolimus. As you can see, tacrolimus was not on board. So this is his ICU stay. So you can see that the creatinine value continues to go up, which is not unusual. These patients do have ischemia, reperfusion injuries, significant fluid fluxes, and then the use of medication and host of other reasons because of which their renal dysfunction continues to persist or linger on into the post-operative period before they start to get better. But you can see that even on the 4th day, this patient has not been treated with any tacrolimus. And of course, on our unit, we don't use induction therapy either. And the only immunosuppression that he is on is the corticosteroids, the antimetabolites, and a very low dose of Everolimus, which continues almost till the 5th post-operative day. So what we do in this scenario is that you look at the urine output along with the serum creatinine values. And if the urine output is not tailing off, then the serum creatinine values probably do not mean much. Continue to look at the graft function, make sure that there are no technical issues. And of course, we continue to look at the urine protein excretion. But please remember, this comes with a caveat. Once somebody has got an acute kidney injury or there is an exacerbation of renal dysfunction, the urinary protein excretion might lose its discriminant value. And it's only with experience that one would be able to completely place into perspective the importance of the urine protein excretion. So the key questions that need to be answered in a patient who gets transplanted with renal dysfunction is whether you are dealing with AKI or chronic kidney disease, how sick is the patient, what was the indication of the transplant, whether you used any induction immunosuppression or not, are you going to be using the CNIS late, which is what is the strategy of our unit, anti-metabolites early, which is the strategy of our unit, and mTOR inhibitors, and this is our preferred approach in these patients. We try to postpone the use of the CNIs till such time you start seeing a downtrend in the creatinine values along with an improved urine output. So this is what we do in patients who present with this kind of a scenario, which is very common in our day-to-day practice. So this is the follow-up charts on this patient. So you can see that the tacrolimus was only added on day 5. And then again, there is a significant gap. So it is not as if to say that you are targeting a given trough level. So as long as the allograft function is good, you are having good Doppler studies on these patients, there is a gradual improvement in urine output, and there is a gradual reduction in the drain output of these patients, you know that you are doing well with respect to the patient's outcome. So the maintenance in immunosuppression in this patient was that the tacrolimus initially in the first month, 1 month was only twice a week, and then it was only once a week. Whereas Everolimus was given in the dose that is highlighted on this slide. Again, like I said, that we are looking at lower levels. So you saw in the earlier pivotal trials that the dose of Everolimus in those patients in whom the CNI was eliminated was to the tune of 6 to 10 nanograms. I think in our patients, we can probably do well even with a much lower dose. If the patient's hematology persists, the patients do not have profound cytopenias, you can be a little liberal with your anti-metabolites. And then, of course, the prednisolone can be kept a little longer in this cohort of patients till such time the graft function really stabilizes. So again, this is something that we've started to do in recent times, not at the cost of metabolic aberrations, but a low dose of steroid is always very helpful in keeping the CNIs away till such time this graft has truly homed in. So I think the important message from this particular case scenario is that here is a patient who has got some degree of renal dysfunction. His comorbidities you cannot change. We know right from the outset that the protein excretion is not extraordinarily high, even though he's a diabetic, and therefore we felt that it was a safe strategy to introduce CNIs late and have this patient on low dose of CNIs, a full dose of anti-metabolites, and a slow steroid taper. So I think the summary and practice point from this particular case scenario is that liver transplant in the MELD era is being increasingly done for patients with renal dysfunction. We are also transplanting patients who actually do not have a stable renal function. So please remember the Cockcroft-Gault formula and all these formula are good only when the patient has had a stable creatinine value for a while. But nowadays, most of us are transplanting patients whose creatinine values are in a state of flux. So this particular condition is called an acute kidney dysfunction. And then some patients who are actually not acute kidney injury or acute kidney dysfunction, but they have got established CKD, and we are transplanting with liver transplant alone even patients with a CKD of 4. We must have a very careful assessment of their measured GFR or estimated GFR and the degree of proteinuria in the pre-transplant period so that we can optimize their immunosuppression. And of course, what we opt to do is late CNI initiation, a low or a very low dose of CNI, and then in certain select situations and in a proportion of patients, we go with a completely CNI-free immunosuppression. So let's now switch gears and move on to the second particular area where the mTOR inhibitors are of significant importance in the post-transplant scenario. So these are immunosuppression strategies in liver transplantation for HCC. So like I said, that almost 20 to 25% of transplant activity in most busy centers across India as well as the world happen for patients with the HCC. So let's again try to drive home our immunosuppression protocols in patients with HCC through a case. So this is a story of a 62-year-old male who's known to be a diabetic for 15 years, and he was evaluated for liver decompensation and found to have chronic liver disease. His initial lab data suggested that he had a low hemoglobin white cell count and a platelet count. The enzymes are as mentioned. He had mild hyperbilirubinemia. The renal function and the serum sodium values were fine. On ultrasound, the sonologist reported that he had got at least 2 liver SOLs. The portal vein was free and there was no other vascular involvement. His tumor marker suggested an alpha-fetoprotein value of less than 10, a PIVKA2 value of 45, and his viral screen, including the anti-core protein, was negative. So this is basically a story of a long-standing diabetic who's decompensated, but at the time of evaluation was found to have 2 liver SOLs. So he was referred to our center, and wherein the imaging showed, a cross-sectional imaging showed that he had got at least 3 lesions, one of which would only be called LIRADS 4 at best. The other 2 were LIRADS 5. The size has to be more than 2 centimeters. So they had typical features of non-peripheral arterial phase hyperenhancement and portal phase washout. He had one prominent periportal lymph node, which was 17 mm in the short axis diameter, but it was deemed appropriate to do an EUS for this and take FNAB from it. And this was only suggestive of reactive changes. And then he was subjected to a PET scan just because he had this lymph node. And we found that this PET scan, the liver lesions were PET non-avid. So this is just one of the observations. So you can see the non-peripheral arterial phase hyperenhancement and the portal washout with a kind of a pseudo capsule that you see in the delayed phase. And this patient had a PET negative liver lesions. So his diagnosis was that he had a multicentric HCC, which was well within the Milan's criteria. There was no extrahepatic or vascular spread, and this patient was waitlisted for a deceased donor liver transplantation. He underwent liver transplantation after a waiting period of about 6 weeks or so. His explant showed that the tumors, it was consistent with moderately differentiated HCC with background cirrhosis. The tumor was confined to the liver with no capsular breach, There was, however, microvascular invasion, and there were no perineural invasion noted. There were no lymph nodes or major portal vein invasion of this lesion. So this is what the explant showed. This was the segment 8 lesion, which was probably the largest one. Then this is the microvascular involvement in one of the septal vessels. So please remember that our full verdict on a patient who gets transplanted for HCC can be given only after the explant has been studied. So what is the extent of the tumor? Are there any lesions which were not picked up on the imaging? Whether there is any lymphovascular emboli, perineural invasion, the degree of differentiation of the tumor, and immune histochemistry to know the lineage. So you subject these tumors to a host of immunohistochemical stains before you can tell whether these are going to have a significant impact on the patient outcome. So you do things like hepa, arginase, so on and so forth, and the bad molecules like beta-catenin, cytokeratin 19, so on and so forth. So these will tell you one way or the other whether the tumor is going to have a greater chance of coming back into the new liver, or whether whatever you have recorded on the pre-transplant imaging is actually falling in line with the explant histology and the explant biopsy evaluation. Some of these tumors would also be post-locoregional therapy, because many patients who are waitlisted also undergo locoregional therapy, and therefore the explant evaluation of the necrosis of these lesions which have been subjected to locoregional therapy is extremely vital. So those tumors which necrose greater than 90% or completely tend to have a much better outcome, even if these lesions are slightly large in size. So this is what is called as the tumor report card following the explant evaluation. So what is the role of the mTOR pathway in patients with HCC? So please remember that you have got the mTOR complex 1 and mTOR complex 2, and the mTOR complex 1 is a central regulator of cell growth proliferation, and this is through activation of the S6 kinase. And many a times you can do the S6 kinase staining of the liver, the normal liver, as you can see in this panel. On the left side is the normal liver, and on the right side is the HCC tissue, and this is avidly taking up. So please remember the mTOR pathways engage in almost 40% of patients with HCC, but it must be remembered that there are upstream steps and downstream steps. And that is why the mTOR inhibitors per se as a chemotherapeutic agent in patients with HCC have really not been very useful. So therefore there are redundant pathways, and there are other multiple pathways which are involved in tumorigenesis, and therefore these particular drugs have not really made a mark when it comes to treating the patients with HCC. But of course the mTOR pathways are engaged in almost 40% of patients who have got a liver cancer. So what has been the story behind the use of mTOR inhibitors in patients who have been transplanted for HCC? This was the trial which was one of the largest trials published in this space, and this was of course with sirolimus, and this was a prospective randomized control trial. So there were two arms. The SRL arm that you see on the left is actually also a low dose CNI arm, whereas the standard CNI arm is what you see on the right side. So about 250 plus patients in either arm. At 5 years, the number of patients who were on the same immunosuppression, the stable immunosuppression, was more than 50%. The recurrent-free survival and the overall survival was found to be same. So this was deemed to be a kind of a negative trial. But however, a post-hoc analysis showed that the patients who were on the sirolimus, which means that also includes the low CNI arm, they had a slightly better recurrent-free survival as well as the overall survival. But as you can see, the 95% confidence interval is touching 1. And the subgroup analysis showed that this benefit was actually seen in patients within Milan's criteria. Now, you might have thought that somebody who's beyond Milan's criteria is the one in whom you would find some benefit or some role of patients treated with mTOR inhibitors as a part of their immunosuppression. But this particular study highlighted the fact that those who are within Milan's criteria are the ones who did better. The study also highlighted that patients who were young, that means those who were less than 60 years of age, those who had an AFP value of more than 10, they are the ones who stood to benefit from the use of the mTOR inhibitors. More importantly, patients who were treated on a continuous basis, at least for 3 months with sirolimus, also did better than those in whom frequent fluctuations were made on account of the graft function or dysfunction, and their period of this mTOR inhibitor administration was abbreviated. So important message is that if you have to keep fluctuating the doses of the mTOR inhibitors, then probably the benefit of the use of these drugs goes away. So coming to the agent that we know now use in current day practice, which is everolimus. So this is the study that I have already alluded to with respect to the renal protection. The offshoot of this study was what happens to the patients who got transplanted. It's about a 1/5 of the cohort got transplanted with HCC indication in the H2304 study and its extension. And you can see that month 12, month 24, and month 26, those who were treated with everolimus vis-a-vis those who were in the TAC control arm, the tumors were significantly, the cumulative HCC recurrence was significantly lower at month 24 and month 36 in the everolimus arm. So this particular drug definitely has got some protection to offer in patients who get transplanted for HCC. More importantly, in recent times, and this was the Asian study and the Asia-Pac study, which was the H2307 studies, in which some Indian centers also participated. Again, a run-in period of few weeks, and then the patients were randomized to everolimus and reduced TAC arm and the TAC control arm. And then these patients were followed up. Here, more than 40% of patients had tumor as the indication for HCC. Also, the criteria for inclusion was not as restrictive. So in H2304, Milan's criteria, only patients could be enrolled, whereas here any number of tumors, but there was no extrahepatic spread or macrovascular invasion, they could be included. So what did the analysis show? So then the number of patients in each arm was about 140 plus. The HCC total number of patients in both the arms was almost similar, and HCC as the primary indication of transplant was also similar in the two arms. However, there was some difference which might not have been statistically significant, but which is worth highlighting because that could have affected the results of the study. The mean number of lesions, the diameter of lesions, the tumor diameter, total tumor diameter, and the alpha fetoprotein value. So you can see that in the TAC control arm, these are all much greater. So the largest tumor size, the total tumor diameter, and the AFP. So these were significant in the TAC control arm. Of course, because the numbers are large, you do not get a statistical significance, but that is something to make a note of when we analyze these results. So what did the authors find? That at month 12, in the everolimus and reduced TAC arm, there was hardly any HCC recurrence, and at month 24, there was one recurrence, whereas in the TAC control arm, this was much higher. And therefore, the message is that if you use the mTOR inhibitors in patients who are being transplanted for HCC as the indication, these agents have got some protection to offer. So please remember that in the transplants done for HCC, many a times the recurrence happens in the extrahepatic sites. And this is indeed what was seen in the H2307 study also, wherein the tumors happened to occur in the extrahepatic site. Of course, there were some which happened in the liver also. So death due to HCC recurrence was 1 out of 142 in the everolimus and reduced TAC arm, and 1 out of 141 in the TAC control arm. And discontinuation of study drug due to HCC was in 3 out of 141 patients in the TAC control arm, but none in the everolimus and reduced TAC arm. So this goes to show that it's a sound strategy to use mTOR inhibitors with reduced TAC in patients who are being transplanted for HCC. But one could argue that maybe one could have gone lower on the TAC trough levels, and maybe one could have started the everolimus much sooner. So as you saw in the H2307 studies, the mTOR inhibitors were only initiated after the first few weeks of transplant. Now this, what you see on this slide, is the largest meta-analysis for tailored immunosuppression HCC recurrence with respect to the use of mTOR inhibitors. So this meta-analysis included 23 studies, 17 observational and 6 randomized controlled trials. 13 were reported on sirolimus and 10 on everolimus, and the recurrence-free survival with mTOR inhibitors at 1 year, 3 years, and 5 years was better. However, if you see the 5-year one, that crosses the 95% confidence interval, but definitely at 1 year and 3 years, it's quite significant. The overall survival was also much higher in the mTOR inhibitor group than the CNI controls at 1, 3, and 5 years, and the recurrence rates was significantly lower in the mTOR inhibitor group by almost 33%. So I think this meta-analysis also drives home the fact that the use of mTOR inhibitor in this particular indication is a sound immunosuppression strategy. So what did we do in our particular patient? So this patient we initiated on corticosteroids as we always do, and we started what we call as ab initio everolimus. That means we started right from the day one of transplant, and that is our first immunosuppression. We start these patients on low dose antimetabolites. Please remember the antimetabolites are neutral when it comes to their impact on tumor recurrence. The TAC was initiated only after 5 days of transplant when the transaminases had almost plateaued off. You don't want these patients to reject, because then you will have to give them a much higher dose of immunosuppression. There was a gradual titration of the everolimus dose till this patient reached a stable maintenance immunosuppression. So the summary from this particular case scenario is that we are all transplanting many patients with hepatocellular carcinoma. There is a high risk of tumor beyond Milan criteria, but we know that the biological behavior of the tumor is not completely captured by the Milan criteria too. That means you could have some patients who are well within the Milan's criteria and they would have a tumor recurrence, and this is anywhere to the order of 15 to 20% in the first 3 years of transplant. We know that the mTOR pathways are definitely invoked in patients with HCC, but they might not be the only pathways invoked, and that is why you need to have a kind of an open mind to the approach to patients with HCC. Many patients in whom we are transplanting, at least in our unit, the strategy is to start the CNIS late and keep the mTOR inhibitors as the principal immunosuppression, at least in the first few days after transplant. But however, this particular strategy, whether it is good or bad and cuts across indications and etiologies for HCC, has to be studied in large multicentric prospective studies so that we can come to much more crystallized results. So with that, I would like to end this session, and I would be very happy to take any questions. Thank you so much.
Thank you, Dr. Thank you, Dr. Ramesh. Dr. Sudhinder?
Hi.
Hi, Dr.
Hi,
please go ahead.
Hi, Dharmesh. Hi. Yes, I did manage to hear your talk. Didn't miss it. Thank you so much for that very clear and very succinct talk. You brought out all the major points. I can just add on that a couple of other areas where I tend to use everolimus is one is when somebody has had a rejection, and they've been on adequate dose of tacrolimus and mycophenolate. I often tend to change mycophenolate to everolimus so that they got a slightly stronger immunosuppression. And I don't have clear data on that, but somehow that seems to work in terms of avoiding repeated rejections subsequently.
Yeah.
Another area is, of course,
I completely agree, because even in the H2304, if you see that those who were on everolimus and reduced TAC, they actually tended to have fewer biopsy-proven acute cellular rejections, and this strategy also holds for allograft dysfunction. So there will be some proportion of patients who will have some kind of a niggling graft injury, and in that situation, probably everolimus definitely helps.
Correct. Yeah, thank you. One other area, obviously, is where there has been some sort of significant toxicity to tacrolimus, like convulsions or HU or something like that. Obviously, you would want to either cut down completely or decrease the dose to a very, very minimal dose, and then use alternative immunosuppression, which, of course, the first thing that comes to mind is always everolimus. Yeah. 2 points. One is whenever I've started everolimus early on, because I also wanted to start early on, and then I tried that. But in those patients, 70% of them did get, pretty bad incisional hernias. Even when I start later on, by 1 month or 2 months, the incidence of incisional hernias is significantly higher compared to no everolimus. I don't know if you find that, or did you find that?
So we haven't looked at that data very critically, but of course, in our unit, we are transplanting almost more than 70 to 75% patients with renal dysfunction. So probably there is a bias towards use of mTOR inhibitors, but I would concede that definitely the problem of incisional hernias post-transplant is a real one in this cohort of patients.
Yeah. So one question I had was, what do you do when with somebody with a renal impairment? You started on everolimus, and then slowly they start getting significant proteinuria, like more than a gram, 1.5 gram, etc. What do you do in that case?
So if the proteinuria crosses 800 milligrams per day, and again I said that for that we should know the patient's comorbidities as well as baseline proteinuria, then we would be averse to continuing everolimus. But then this cohort is also a cohort which probably would do with very little immunosuppression. So it is not as if to say that you jump to putting back a CNI on table. You try to manage these patients with corticosteroids and anti-metabolites. So that would be our strategy. But we would definitely take off everolimus in patients who have significant proteinuria.
Yeah, thank you. I think we do the same thing, actually. We do exactly the same thing. Any other questions, anything? And are you okay to use everolimus and mycophenolate together, given that they both have bone marrow suppression?
Yes, we do. So I think, again, that is one of the reasons why the pivotal trials could not glean the true benefit of the mTOR inhibitors, because I've always believed that it is the net state of immunosuppression that counts. So whatever the trough levels tell you is only a part of the story. So as I've often said in many of interactions, that we don't do the levels at all. So I would do the levels only if there is an allograft dysfunction or there is a renal dysfunction or side effect. Otherwise, I would not do trough levels at all. So we follow the policy of probe tolerance, which means that every time the patient comes to you, you should probably have a mind to keep lowering the immunosuppression till such time, you have reached the nadir. Though I still don't know what that nadir is, but we would continuously make an attempt to lower immunosuppression if the graft function is stable. And I think one more point comes to mind just from the points that you mentioned, that when we talk of tolerogenic immunosuppression, so we know that mTOR inhibitors are a component of the tolerogenic immunosuppression. So again, this is one part of immunosuppression strategies that hasn't been well studied. But if you are one of those who strongly believes that there can be a proportion of patients who can be taken off immunosuppression, I know none of us are so gutsy in this part of the world, but there are people who do that. And again, there the CNIs are culprits, whereas mTOR inhibitors typically provide that tolerogenic stimulus when you have got the first release of the donor antigens come into your bloodstream.
Yes, the TREGs and all those things, isn't it? T regulators and all those things. I think they do have a part to play in the immunogenicity, immunostasis, so-called. What about incidence of interstitial pneumonitis? Have you ever had such patients?
Yeah, so this particular thing was oft talked about in the sirolimus area. Haven't seen too much of it in our times, including during the COVID era. However, if patient who's been on any dose of everolimus, and even though this patient might have been very stable, if they present with any respiratory symptoms, we would take off this molecule.
Okay. I think another myth is the myth that everolimus can actually lead to hepatic artery thrombosis, which is the reason why we give our hormones. That is completely wrong. It is just based on 2 or 3 single case reports, that too with sirolimus in very high doses. In fact, now if somebody has got a hepatic artery, stenosis, etc., sometimes we tend to start on everolimus because it does have an anti-fibrotic effect.
Oh, absolutely, and that's what the cardiologists put in their stents. So
exactly, absolutely, yeah. So I think that was a very, very illuminating talk.
Thank you so much.
One more question.
If there are any questions in the chat box, can somebody?
Yes, Dr. Sridhar, you were saying something.
Yeah, sorry. What? Yeah, so with this HCZ thingy, I mean, how long do you give the everolimus? I mean, do you give it for 5 years and forever, or is there any recommendation on that?
Right. So when it comes to HCC, like I said, that is our initial immunosuppression in these patients, especially those in whom one is slightly touchy with respect to the tumor load or with respect to their local regional therapy or downstaging or the time on the wait list. And like I said, that initially, because the explant turnaround time is a few days, you don't get the explant report almost immediately after surgery. So that can give you some leverage, but in most instances, this would be continued for a long period of time. So our strategy in these patients is to continue to lower the CNIs and continue some maintenance mTOR inhibitors. And of course, the surveillance program is in place, which is a very stringent one in the first 3 years, slightly less stringent in up until 5 years. And after that, it would be on a case-to-case basis.
Thank you.
Excellent. So if there are any other questions, please do include them in the chat box. Dr. Dharmesh, at this point in time, we don't have any other questions.
Sure. If they are, they can probably be sent across to either Dr. Sudhinan or myself through email. We'll
Certainly.
Yeah, that's fine. No problem. Yeah.
So,
Yep.
Thank you so much indeed. Thank you
And
so much.
thank you that you could join. I was
Yes, no, I didn't miss that. I didn't want to miss your talk anyway. Thank you.
Thank you. Cheers. Good night. And
Okay,
thanks
bye-bye.
to Concord for organizing this event. Thank you.
Yes, indeed. Thank you.
thank you so much, doctor. Thank you so much.
Bye-bye.
Bye and thank you. Have a good evening.